Well, good morning, everyone. And we are glad to have you here with us for a conversation about where we are with COVID in this June 24th, 2021. And so with us, again, our resident expert, Dr. Tim Babinchak. Tim, would you like to just introduce yourself to the group a little bit?
Sure, absolutely. Thank you again for having me. An infectious disease physician for the past 40 years, formerly the chief of infectious diseases at Thomas Jefferson University Hospital. I retired from active clinical practice in January of this year. I worked through the beginning parts of the pandemic and very involved with activities concerning the coronavirus, not only here in the United States, but globally, including the development of both the therapeutics and the vaccines that we have available. So, and it would be amiss if I didn't give my association with St. John's in Phoenixville as being my guiding folks that have been very influential in my community as well. So thank you all for having me, and I appreciate the opportunity, and I'll do my best for you.
Well, thank you, Doctor, for being so gracious with your time. This is the second program we've done, and you've also been very helpful giving us updates by email in between. So we truly do appreciate that. So here we are, we're at the beginning of the summer, and we're seeing cases decline. We're also seeing the number of vaccinations decline. Pennsylvania is opening up. We're seeing news just this morning. The AP was reporting about an outbreak in Missouri among unvaccinated folks, and some cautions in the European Union about possibly slowing down reopenings because of the Delta vaccine. So what's your top line sense of just where we are right now in terms of the virus?
Yeah, absolutely. So a couple of points that I do want to start off with, and let's start with where we are in the good news aspects of things. So vaccine, and you'll hear me saying this repeatedly throughout today, vaccine is the key here. And this is the message that I think is being provided by the other public health experts as well. But vaccine is clearly the key. In our United States, the most vulnerable populations have seen an excellent uptake of vaccine. So the older age groups, the 85 and older age groups, the nursing home groups, greater than 80% of them have received vaccine. And that's very, very important. And as you look at the chunks of individuals going down from those older age groups, you see progressively lower and lower levels of either partial or full vaccination. And it's been in the popular press that we will not be meeting the 70% of the American population vaccinated by the 4th of July, based on the current trends that we're looking at. But we're remarkably close. And that's why I say the good news is, for those that are most vulnerable, that metric has been met. Where we still see room for progress is in the younger populations, particularly those under the age of 40. And then the next group are those under the age of 25. And that's where the uptake of vaccine has been the lowest. And there are a number of reasons for that. And my goal here today is not to go through those, but just for our information to understand where those at-risk populations remain. Because when we talk about the risks around coronavirus now and COVID-19, it really exists in the unvaccinated population. Those are the people who continue to be at risk, and they will be at risk. And that's where you're going to see these outbreaks. And so the background for these variants is basically nature abhors a vacuum. So as the world became vaccinated, or as a virus goes through a population, mutations occur to that virus regardless. And the mutations that are in favor of the virus are the ones that then get propagated forward. And you have new strains of virus that take over from the old strains. So these variants provide an advantage to the virus to continue its infection. The particular variant that we see growing in our country and that has come from India and from the UK and around the world is the so-called Delta variant. And now, just simply, there are literally thousands of these variants, but one or more of them become dominant. And the World Health Organization has taken it upon itself that they will designate these with Greek letters, hence the Delta variant, in order to not stigmatize any particular area where these viruses may have originated. But that's just the naming convention. So the Delta variant. The Delta variant has been taking over the circulating virus pool within our country. In the past month, it's gone from less than 3% to now at least 20% of the virus that continues to circulate. Now, where does that virus circulate? That virus circulates in our unvaccinated population. And so if the vaccinated population doesn't mean that the virus can't circulate there, but it is much, much less likely to, all right? Because the vaccines are not 100% effective. The vaccines are 90 to 95% effective, even against these variants. When I say effective, what I mean there is that the vaccine is very good at preventing severe illness that will result in hospitalization or death. It doesn't mean that you can't get sick. It doesn't mean that you can't get the virus, but it's much less likely. Any illness is more likely to be mild, and the ability to shed the virus is much less likely in the vaccinated population. In the unvaccinated population, your risks are the same on June 24th, 2021, as they were on June 24th, 2020. And because the Delta virus, so the thing that makes it a better virus than its grandparents and great-grandparents is that it is more transmissible. It is more easily transmitted. So the virus that we're dealing with now, this Delta variant, is transmitted more easily than the virus that we were dealing with 6 months ago or a year ago. That actually makes it a little bit more dangerous, again, for the unvaccinated population, because they're more likely to become infected by the Delta variant this year than they were by the previous variants that occurred 6 months or a year ago. And that's just the natural progression of these viruses. This is, those of you that were here for my first one, this is the world that we live in. This virus isn't going away. It's never going to go away. It's just going to reach a steady state that we're going to have to deal and live with, much as we deal with influenza virus. So my major activities are toward getting information out to get as many people vaccinated as possible. And by doing so, we have the best chance of limiting that spread. And that's what you've seen over the last 3 months since I last talked to you. As vaccine rates increase, the ability of the virus to cause severe disease decreases. And this has been shown not just in our country, but in other countries around the world who are actually ahead of us in vaccinating their populations. One other aspect of the variants that I do want to touch on is what the potential is for needing revaccination at some point in the future. Now, recognize that we only have experience for as long as we've had vaccines. So we know that the vaccines, the people who were first vaccinated in the clinical trials, even starting a year ago, we know that their vaccine is still effective against these variants, against these Delta variants. So we know that immunity lasts at least a year. And from everything that we've seen so far, there doesn't seem to be a need for a booster at 1 year. Now, 6 months from now, a year from now, that will all have to be taken. That's all being followed very carefully, because we may get a variant that is not vaccine susceptible. We may see that our own immune systems over time degrade to a point that we do need booster doses. But as of June 24th, 2021, that's not the case. That's not what we've seen here in our country, nor have we seen that again in other countries with vaccines and with their susceptible populations. So the good news is that vaccination is still the key, in reducing all of these things, and the key to opening up and having our systems, our congregations, everything in our societies open up to a point that reflects the safest opportunity for the individuals that are involved. And that's really what this is, okay? And when we talk about what the next steps sort of are, it's based upon the risk assessment still for those individuals who remain at risk. And the individuals that remain at risk are those that are unvaccinated. Bob, I hope that answered.
Yes, thank you very much, Doctor. And that's a very important question, I think, for us in churches, thinking about, there's so much information coming from so many different directions. Some of it is accurate, some of it is not accurate. So where would you suggest that we be paying attention so that we are getting facts, but we're not being overwhelmed?
Yeah, that's an excellent point, and that it is often very difficult. I will tell you the sources that I recommend routinely, particularly within our local area. The Children's Hospital website, their COVID laboratory, does an excellent job of tracking what the number of infections that are occurring within our local southeastern Pennsylvania. And it actually is a very good website for seeing what the activity is like in our local area. And it's broken down on a county basis. It tells you the positive tests that have been occurring. And so it gives a very good look at what the what our local transmission rates are. And I can provide the URL addresses for these. So at the local level, Children's Hospital of Pennsylvania, it's right there when you go to CHOP, and it's under their COVID resources activities, and it's very easy to use. It has a map of the state of Pennsylvania. It's very intuitive. That gives you the snapshot of where we are on a county level. All right, and the various counties around us as well. That's one site. At the national level, please continue to look at the Center for Disease Control, cdc.gov, and their COVID resources. They're responsible. They are the best information that they have at the time. And the only part of this is that whenever you look at any of these sources, understand what the purpose of that particular source is. So what I mean by that is the CDC's activity is public health. So the recommendations that they're making may not necessarily be pertinent for all aspects, because their main purpose is to ensure the greatest public health for the greatest number of individuals. And so that information needs to be looked at with the particular lens or the outcome that you have in mind. The goals of the government aren't necessarily the goals of the church or the goals of big business or restaurants or gyms or other individuals that way. But so at the local level, the CHOP, at the national level, the cdc.gov is the best. And quite frankly, at the personal level, if you have personal questions, please, telemedicine, your own healthcare providers and your own healthcare network can be very useful in answering those particular questions, specifically around vaccines and vaccine questions, the vaccine hesitancy issue. That must be a conversation that you have with your healthcare providers and professionals. They know your medical situation the best and can make the best recommendations for that.
Okay, thank you. So, Doctor, one of the things that we've been thinking about, churches have two vulnerable populations. We have adults who, for whatever reason, can't or won't get a vaccine. And then we have children who, of course, can't be vaccinated at this point, especially younger children. So what do you think are appropriate precautions for churches to be taking right now?
Right. Perfect. And this is unfortunately, I don't think that we're ever going to get out of this situation, because we're always going to have people who are unprotected. Just as we have people who don't get flu shots, there will always be people who are unprotected. The question is the perfect one that you raise, is how then do we manage and deal with the risks that those folks are now assuming on their own, essentially. And my recommendations are really not a lot different than they were when we did this a few months ago. And that is, as long as there are people at risk, each congregation is going to need to take its own sort of temperature and determine how much of that risk they're willing to accept within their congregation. So you remember we talked about the who, what, when, where, why, and how long of this. So transmission is greatest in enclosed places where you spend a lot of time with individuals who could potentially be sick and in the various activities that they're doing. So what can we do practically? And we've gone from a situation where we've social distanced everyone to now the question becomes, can we social distance those vulnerable populations? And that's a very difficult aspect here. And what you can do, my recommendation is you can ask, and you need to have people be willing to self-identify and take some responsibility on their own. And so when I get the question, do we still have to social distance in our services within our church? My suggestion is family units that have been vaccinated, et cetera, are at much lower risk. And so the 6 foot down to 3 foot, depending upon the sizes of your worship spaces, need to be taken into consideration. But what you can do is ask those who are still vulnerable or unvaccinated to continue to A, wear masks, and B, social distance. Now, that doesn't necessarily mean that you're creating a separate section of the church for those individuals, but for them to take on as a degree of personal responsibility and say, hey, I'm here, I want to be part of the community, understand that as being part of that community, you're being asked to take into consideration your fellow parishioners in that regard. Specifically, the second point that you talked about, those adults who aren't, that sort of takes care of those adults who can't be or won't be vaccinated. For the children, again, getting as many of these children vaccinated as possible is the key. It's the key not just for church, it's going to be the key for school. It's the key for limiting the development of these variants as well. And it's the key to keeping the vulnerable populations as safe as possible. I totally anticipate that by the September-October timeframe, now we currently have vaccine that's approved down to the age of 12. By the time we get in the next quarter, the September-October timeframe, that's very likely, Pfizer is very likely to have approval of that probably down to the age of 5. So all of our school-age children will likely be able to have vaccine at about the time that school starts to begin, or if not by then, at least very shortly thereafter, definitely by the end of the year. So that will give the opportunity for school-aged children to become vaccinated as well. Going back to the who, what, when, where, why, and how. For most services that are an hour long in the churches, the risks are not as great but that depends upon how many people you have, how much vaccine, how large of those people are vaccinated, and what their risks are in those particular areas. For the most part, indoor activities should should still be social distanced and masked to the extent possible, particularly those who self-identify themselves at risk, unvaccinated or at higher risk. Outdoor activities can be done without masks. So if you're having services or conducting services outdoors, the need for masks is not necessary. And that includes the speaking aspects as well. And I know, Reverend, you and I went back and forth. We can cover the singing aspect next, or if you want me to clarify anything that I said.
No, I think you've been very clear so far. I thought maybe before we jump into that, give people a chance to give us some feedback in a couple of polls that we have, just to see where you are as congregations. So the first one asks how your congregation is currently gathering. And you should now see it on your screen. And you are welcome to vote. So we've got 85% at the moment. Any last votes? Okay, well, let's end this poll and take a look at the results. And as you can see, indoors and online is the largest combination. I'm glad to see that the two largest are indoors and online, and outdoors and online. And a very small group that are still online only. And we'll get to a question about that in a moment. So second question asks about the precautions that you're taking. So take just a moment here to add your thoughts.
Just Bob, just a comment. The question of require versus encourage.
I think you could read that as require or encourage. Okay, so it looks like most everyone has gotten a vote. Give you another 10 seconds for anyone who wants to sneak in under the wire here. Okay, and let's see what the results look like. So slight majority is requiring or encouraging use of masks and social distancing or physical distancing. I hate saying social distancing between households. And very good. Everyone has an online option. Everyone who voted. That's really, really exciting. So question that was just raised in the chat from Lynn. The question becomes, do they do it, and is it enforced by the leadership? And that, of course, is going to be a decision that's going to be made locally by your congregation. So last question, and this gets to what Dr. Babinchak was going to launch into, is how are you doing singing, if at all? So please take a moment to vote and let us know how you're approaching that.
Bob, you don't have no singing at this point. That's not an option.
I would then not vote, and we'll know that. Okay. Any last votes for the singing poll? Okay, and let's look at the results. So an equal number of folks are doing masked and unmasked singing indoors. Most folks are doing unmasked outdoors. Almost everybody's has the congregation singing, and interesting, fewer people have choirs or singing leaders. So that is really excellent. And Pastor Bleem raised a really good point. So if you are not including any singing in your worship, would you please raise your hand? Okay, I see 3, and of course, some of you have no video, so I'm assuming you're not raising your hands. Okay, thank you very much. Before we move to singing, Dr. Babinchak, I want to ask a question that came up. One of the things that's very hard for churches is figuring out how to know if people are vaccinated. And that's everyone is facing that. I hear airlines are starting to push for some kind of electronic verification. But the question that was raised directly was, I was told that it's a violation of someone's civil rights to ask if they have been vaccinated. I know that's not your particular area of expertise, but what do you know about that?
Now, so when you play back the transcript, I'm very careful around this. And my recommendation is for people to take on personal responsibility and self-identify themselves, not as vaccinated or unvaccinated, but as vulnerable or in some way that. So directly, it's not a violation of anyone's civil rights in order to ask them whether or not they're vaccinated any more than it's a violation of their civil rights to ask if they've had a flu shot or any other vaccine. All right, it's a matter of whether or not they care to answer that question truthfully or not truthfully in that regard. So asking the question is not a violation. Now, discriminating based upon vaccine status and not having admittance in certain things is something that will play out, and you see is being played out. at this point in time, and that's why I was very careful in going through what those percentages are. So you can act on the basic percentages for your congregations in just looking at what those overall totals are and assuming that that's what it is in your congregation. The bottom line for healthcare providers is we don't care. We assume that everyone's unvaccinated and we're going to treat you in that way. So we're still going to have our masks on. We're still going to do things to keep you as protected as possible. And that's why I say it's up to the individual congregations to determine how far they want to go in having this information. And basically, it's a matter of, for us, for me, it is a matter of stressing the personal responsibility that we have in this, just as you would for your vaccine for influenza or for any of the other things. You know, for years before COVID, we always said, if you're sick, don't come to work. If you're sick, don't come to church because you're putting other people at risk. The world is no different. COVID is nothing special over and above that. So everything that we used to do and say, wash your hands, do all of the good things, still remain, right? Not a violation of your civil rights. Just understand that people may or may not be giving you an answer or giving you a truthful answer in that regard. But as a society, we're going to have to learn how we're going to deal with those individuals. The most successful that I can recommend is placing that personal responsibility now onto those individuals because they have very, very important to them reasons for either not being vaccinated or whatever. And those are as legitimate a set of values and reasons as on the opposite side. What we ask, though, is for the protection of the greater community, that those individuals take that then as a personal responsibility, that they maintain the safety of those that are around them, those that they care about, especially in our congregations. And I think that's one of the advantages we have in a church and as a community, that we do have the greater good of those around us really at heart in that situation. It's a little bit different in the gym.
Yeah, yeah. A related question that popped up, at one time, a child could not attend school based on their inoculation requirements. In your opinion, should the same requirements be expanded for this pandemic as well as others?
So now we're going to real public health issues, and I will, as I said in my first, and I didn't say it in this time, I limit my personal opinion here. I try and give answers to these questions based on the totality of the scientific evidence and try and keep the personal aspects out of this. The short answer that I'm going to say is that's going to be determined. The case that was heard by the courts to this point of having a vaccination as a prerequisite for employment was actually upheld because that was a private business. It's not a public activity like school attendance in that regard. So I'm not going to interject my own personal opinion in this from the standpoint of we have certain recommendations for vaccines, for school, for certain diseases, and it's going to be up to our public health officials and our politicians to determine whether or not this may be added to the list. Influenza is not one of those that is added, that is there. But we do have for polio and other other very serious diseases in this situation. So like I say, I'm not going to offer my own personal view there, but we'll say time will tell, and it is something that we need to monitor.
Okay, thank you. So I think it's time to get to the big question, which is, since Lutherans love music and it's an integral part of our worship, what is the science saying about singing? And I guess it also relates to the use of wind instruments as well.
Yeah, so you're absolutely right, and music is a big part of our Lutheranism, but also is a big part of our society. And this is one of the areas that has made that is a special circumstance. Remember, I said you have to take all of this information and then apply it to what your particular circumstance is. And church is different than the gym, which is different than the public schools. So one of the things that makes it difficult is the way that the virus is transmitted. And we do know that singing creates more of the infectious particles that put people at risk. And I shared this with you, Bob, and please, please share that on the screen as well for everyone. And let me just give a little bit of a background to what I'm showing. So you'll all, I can't provide this to everyone because it is the property of the authors, but if you go to the reference down there at the bottom, and this is from the Proceedings of the National Academy of Sciences, you can go to their website, PNAS, and they have a search bar there, and you put in MZ Bazant, which is the lead author's name. This paper comes up as the first hit. And quite simply, what you see in that upper panel where you see the R equals 2.6 microns is the the particle size that is generated by various activities. And you see the relative number of particles going up the left-hand side, as well as the size of the particles going along the bottom there. And the size is important because those that are less than 5 are the ones that can be both breathed in and make it to the lungs to cause infection. The important and the only reason that I put this in is to show that when we talk about most normal activities, mouth breathing, nose breathing, whispering, speaking, it's all relatively low along the bottom of the graph there. But singing generates the most particles of the most dangerous size. And so that's why there have been specific recommendations around singing that tend to be more strict. Now, as I said, you have to consider the source and where this is from. So this is actually a statistical model that was put together by this group of researchers based upon the original spreading event that occurred in the Seattle area very early on in the pandemic. And so all the variables that go into this statistical model are based upon that so-called super spreader event. And it was a choir that subsequently had multiple infections that have come out of it. As I've always taught my students and my other doctors and residents, that is, all models are wrong. Okay, there's no model is correct, otherwise it wouldn't be a model. All models are wrong. Some are useful. This is one of those useful ones. It's not entirely correct because it's based on one set of assumptions, and you put different assumptions in, the lines change, but they don't change dramatically. The point that I'm trying to make is singing is still by far the riskiest behavior that our congregations are going to undertake. And again, that risk is to the vulnerable, the unvaccinated for the most part. So what can we do to help with that? One, singing with masks helps. Second, having the distancing within the church helps. Having those people self-identify distance helps. Limiting the time that people spend in that particular area. Remember, I said most of our services are for less than an hour, and that length of time exposure with ventilation, not an issue. That's why outdoors is always better. You can sing without masks outdoors because those things are getting blown away by the ambient air. And this was one of the questions we had last time, and what we've gotten better guidance on, and that is know the ventilation the ventilation capacities within your particular buildings. The more air exchanges per hour that you can get, the better it is within your buildings. And that's a balance, again, that each congregation is going to have to set, because the ventilation exchanges come with the downside of increased costs for heating and cooling in those situations. So quite frankly, during the summer and when possible, the easiest thing to do is just open the windows.
Yep, the simple response. So, are there any particular recommendations of what kinds of masks should be used for singers?
Yeah, it's not the specialty masks, the N95s. There isn't enough evidence to show that there is a significant difference among them in order to recommend anything in particular over another. So as long as you're using your same double layer mask, that's the best.
Okay. And I know that the ecumenical group that's been looking at how churches live into this put out some guidance just a couple of weeks ago. And I think in their case, they were recommending that gatherings could be an hour or a little more outdoors, but were suggested limiting to, I think, 30 to 40 minutes indoors. Is there that much of a risk?
Yeah. So, and if you go to this paper, there are other graphs within this paper, and I didn't send along that one, and I was going to save that one for later. But the third graph actually gives an idea for a school classroom versus a long-term care facility as to how long people are safe within those particular areas. And for meetings that are at their usual occupancy, that are around an hour or less, almost all of those are in the safe zone. And it's only when you get extended beyond an hour or above what your recommended occupancy is concerned that you start to get into a more at-risk zone. And really, it's not until you are greatly extend that for multiple hours with lots of people that you get into a dangerous zone. So I encourage people who have these questions, again, the paper requires a statistical degree in advanced statistics to understand, but the pictures are fairly explanatory in that for short periods of time, with the recommended numbers of people that you have within your congregations, it is a very low risk, not a no risk, but your risk is lower. And then if you increase the ventilation, you decrease that risk further. So all of these are risk mitigation aspects. We can't take it to zero, but we can do things within our buildings and within our particular circumstances to make that risk as low as possible.
Okay, thank you. There are always questions about this issue. One of the ones about ventilation, and I think a lot of churches will have to get in touch with some experts to figure out what exactly they're getting in terms of air exchange. And we've talked about windows being open. The other question is, should ceiling fans be on or off?
Yeah, ceiling fans are fine. So the reason that ceiling fans are okay is that when people gather together, the heat of our bodies actually warms the air and the warm air rises. And the ceiling fans actually then allow that warm air to go out, and it actually helps to dilute what's coming up from the bottom. So ceiling fans are fine. You're not spreading it any further or any of the other activities. So it's not a matter of on or off. If you can have exhaust fans now that you can put in the windows to help exhaust air ventilation out, that can be helpful. But our churches, some of our churches are very old. Some of our churches, you can't open the windows. And that's why I say each particular circumstance has to be looked at. So if you can't open your windows, it's more of a priority to, as you said, Bob, to get in touch with your heating and cooling people to see if we can't open our windows, can we increase the number of air exchanges that are going through in an hour on our system in a way that we can do it economically with our heating and cooling bills.
Is there a minimum amount of air exchange that would be safe for indoor gathering?
So, and this is information that has become more available. Most public buildings, schools, etc., are recommended at least 8 air exchanges per hour. Okay, as the minimum. So that's every 7 or 8 minutes or so there's an air exchange that's going through, and that would be that's not just for virus activity, that's for just healthy breathing air comfort, accumulation of everything else within a building. So 8 air exchanges is about where we are.
Okay, thank you. Question from one of our churches that has not yet returned to in-person worship. They say that some members are afraid or concerned about returning to church until it has been professionally cleaned and sanitized. And so there's a question of, should that be done prior to starting in-person worship? And then how should that be continued as church goes forward? And second part of the question is, we also rent out our facility for special events. What level of cleaning and sanitizing is needed for the safety of our renters and members?
Yeah, all excellent questions, and questions that we've come to know a lot more about. And that is that normal cleaning procedures that you have in place are sufficient. There isn't anything special about this virus that's any from a longevity on surfaces that is of concern. So as long as you're doing your usual routine cleaning activities, it doesn't require special cleaning activities. And this goes again to even churches that have multiple services, as I said in the original one, as long as those services aren't back to back to back, as long as there is some period of time between one particular service and the next service. The virus uh, viral transmission from surfaces and contact, it has become far less of an issue than it was 6 months to a year ago. And we've learned more and more around these things. The important part is still not so much the surfaces in the church as people washing their hands before they come in the church. And that's the key. Stressing the usual things that we stressed before COVID ever existed, and that is, don't come if you're sick. Please wash your hands, and please be considerate of others.
Yeah, there was a comment in the chat saying that this likely relates to a lot of other diseases, and so that this advice of wash your hands, stay home if you're sick, really applies to flu and common cold and other diseases as well.
Yes, absolutely. And that's why you didn't have a flu season last year, right? Because we were doing all of these right things. Now these other illnesses are going to come back as we come in contact with each other and we start to do these things, because as I said earlier, nature abhors a vacuum. So we will start to see influenza. So this, though, as I said, this is the world we live in now. And COVID is just one of the other respiratory viruses that we're going to have to deal with, along with influenza, along with the common cold, along with the diarrheas and all of the other things that we come in contact with. So it's here to stay. Just as we take precautions around all of those other illnesses, those same things, the same common sense things that we did, still apply.
It's interesting that over the last winter, because of the various precautions, that the incidence of flu was much lower than a normal flu season. So perhaps some of this will be adapted into just our normal, won't be a coronavirus thing, it will be a normal way of functioning. There's a question asked in terms of singing. There's quite a bit of difference between soloists and choirs, is there not?
Yeah, choirs put out, so it only takes one. Okay, and that's the key. So whether you're absolutely right, choirs have the potential for there being more than one, and B, for that individual, for the volume to be greater. But that was the case with influenza as well. All right. So that's why I'm saying that this is now the world that we live in, and we're going to have to take that into account. And that's where, how then can we mitigate that? Can we move the choir farther apart? Can we, mask the choir in that way? Can we ask those who are vulnerable to do the important things for the consideration of others within that? You're absolutely right. That goes to the how many, right? More people put more people at risk in that way. We can't make that risk go down to zero, but what are the things that we can do to try and minimize that risk if we want to, right? And that's what has to be decided by the congregations themselves.
Okay. Back to your question or discussion about the local sources for information. Do you have any suggestions for what metrics we really should be looking at and what the targets are?
Targets are created by people who have a vested interest in a particular activity. All right. My target is as many people as possible. Okay. So targets for spread within the community needs to be as low as possible. My oath is that I take care of everyone to the absolute best of my ability, and to first do no harm, And that means that as long as there is one person who is ill, that's one too many. And so those are my very own personal metrics. And I know I said I'd keep mine out of this. Scientifically, all of the questions around what is herd immunity, quite frankly, we don't know. Right? And what herd immunity means is different to different people. We know that for a disease like measles, you have to have over 95% of individuals vaccinated in order for measles not to spread. And measles is a very, very contagious virus. And we saw that 2 years ago as it spread through in unvaccinated communities among the Orthodox Jewish community in New York and in other areas. And so that's why vaccines are very important. The reason that the metrics are difficult is because that metric is specific to measles. That metric, that 95%, will be different for COVID. We don't know what that is yet, okay, in order for circulation to be so very, very low. And the idea of 70% or 80%, go back to what we just talked about. It's a model, all right? All models are wrong, some are useful. I don't know whether 70% is enough or not. We'll know that as time goes on. So until we know what that is, my recommendation, what really should be recommended, is as many people vaccinated as possible to get the transmission rate as low as possible within that. Making decisions as to when you go to indoor or outdoor are important and need to be followed by the public health authorities as well. And that's why I gave our local CHOP sort of graph that says those kinds of things. The other difficulty I have with setting those types of metrics, as soon as you set a line, then that line is likely to be wrong because it's going to move either one direction or another. And the information lags those particular periods. My crystal ball is as cloudy as everyone else's as to what this is going to look like come October, November, December. But that's why I've committed to you and to others that we'll do this on a regular basis to keep everyone as informed as I can in that regard.
Thank you. So a communion question. One of our churches is planning to return to communion distribution at the communion rail in July. And their question is, should the rail be disinfected between tables of people? And I would add in general, do you have any recommendations for how to do communion as safely as possible?
Absolutely. And we did this. I'll give you my recommendations that I gave to St. John's. And that is, no, the communion rail doesn't need to be disinfected in between the time. The time spent at the rail is relatively short. And so the exposure duration is relatively short. So you don't need to disinfect in that regard. As to the communal, the delivery of the sacrament, how you're delivering the sacrament needs to can continue as you usually have. You don't have to have special activities there, with one caveat, and that is my recommendation would be that those who are delivering the sacrament be vaccinated in that regard. That is the safest activity. So if you do have church leadership that is involved in the delivery of the sacrament, that those individuals should be vaccinated. That is the best way to protect the congregation.
Thank you. And we also love our coffee hours. Is it safe at this point to resume sharing food and beverages?
Yeah. You're again, it's as safe as it's going to get. at this point. All right. That's the key. It's as safe as it's going to get. And as more people get vaccinated, it will get safer in that regard. We don't have, and that's why I wanted to stress the good news in the beginning. We don't have any evidence that this virus is any more unsafe than we were a year ago, with the exception of those who are unvaccinated. And the coffee hours, all of the social activities now, for me, the shift needs to be, again, back to the personal responsibility of, if you know you are vulnerable, or the personal responsibility of not putting others at risk in those particular situations.
And that, as you said, do no harm. And that's
Right.
what Bishop Davenport has been telling us all along, is to make decisions for the safety of the community and of the worshiping community as well. So I think we have gotten through the questions that are in the chat. Okay, one just popped up. With communion, is it individual cups or the 1 cup for distribution of wine?
So so for St. John's, we're doing individual cups in that regard. Again, I chuckle and I laugh because we've gone through this. I remember going through this, being old enough to remember all of these discussions when it came to HIV and all of the others. The communal cup, again, can be shared with the same understanding that the individuals who are doing that are the issue, not the cup necessarily itself.
Mm-hmm. Okay.
And just as we've learned in the common cup, when it goes from one individual, you're always wiping before you give it to the next individual.
Okay. Related to that question, should people distributing food at coffee hour be vaccinated? Should that be a requirement, so to speak?
It is a requirement. No, that needs to be a decision that you make individually. Okay. And the reason, my justification for this looks at what the potential transmission has been within other food service industries. And it just has not been the case where we're seeing these large outbreaks in the delivery of food service, either in individual restaurants or in grocery stores or in other retail type establishments. Again, the period of the who, what, where, when, and why, the period of contact there is so short, and the likelihood of transmission from inanimate objects is low enough that those risks have been mitigated to the greatest extent possible. Is having those individuals vaccinated further lower that risk? Yes, but now we're getting into very small increments of lowering that risk.
Okay.
The bang for the buck theory.
Thank you very much. I think we have gotten through the questions that have been submitted, other than it was asked, are we permitted to share this recording in our congregation? And yes, when the recording is finished, we will make it available. We will have to edit it to remove that copyrighted material, but it will be available. So are there any last questions while we have Dr. Babinchak with us today? Well, I'm going to say, Doctor, you did a really wonderful job.
I have one question.
Yes.
If someone has not been vaccinated and they had COVID, can they catch the variant or catch it again or transmit it?
Okay. Yeah. And that's very important. And that's why I consider everyone unvaccinated and everyone at risk. So in the beginning, you heard me say, even vaccinated individuals are not 100%. So just because you're vaccinated doesn't mean that you can't get the virus and that you can't get sick. What it does mean is that it's very unlikely that you're going to become severely ill, and it's ill enough to be hospitalized, and it is very unlikely that that will progress on to become a deadly case. All right. Now, that's always it's always going to happen because we have individuals that have other underlying diseases, et cetera. So nothing is fail safe. So if you've been vaccinated, yeah, you can catch the virus because not everybody who's vaccinated responds as well as everyone else. That means that you could potentially transmit the virus, and regardless of whether it's the variant or not. But what we do know is that if you've been ill or been vaccinated, that the likelihood and your ability to transmit the virus is much, much less than if you've not been vaccinated. So the time that you shed virus and the amount of virus that you shed is greatly reduced by vaccine.
So if you have not been vaccinated and you've had COVID, then can you catch it and spread it again?
So if you've had COVID in the past and not been vaccinated, you do have your natural immunity from the original infection. Okay. So unvaccinated, you are at a little more risk. That's why we recommend even people who have had COVID to get vaccinated on top of it, because that adds another layer of protection. So even if you've had COVID, we recommend that you get vaccinated because it adds another layer of protection on top of what your natural infection was. But your risk for the variant is no greater if you've had the infection. The variant is, these variants are more risky for the unvaccinated and those who have never been sick.
Thank you for the update. Thank you for all the information. I have a situation where my book club is getting ready to meet. I am vaccinated. About 12 other people are vaccinated, but we have one person who is not, and we're just trying to figure out how to handle that particular situation. But I appreciate all of your information. Thank you.
You're very welcome. You're very welcome. And as I've told Bob, as you guys have these different questions come in, he's taken it upon himself to collate those. And if there is something specific, I am more than happy to answer what I can through emails and others. But I only ask that he be the collector of the information, so that the answer may have already been given by the time different individuals have those questions. So always thankful.
Well, thank you very much, Doctor. And I think we've used up most of our time. So I think now would be an appropriate time for everyone to unmute and we can share our appreciation with Dr. Tim.
Thank you. Thank you.
Thank you all
Thank
very
you.
much. Thank you all very much. This is, I'm humbled. Thank you.